Bismillahirrahmanirrahim. Assalamu alaikum. Today our topic of discussion is Introduction and Preparation of Assisted Vaginal Birth, Green Top Guideline number 26. Incidence of assisted vaginal birth is 10 to 15%, which is more common in nulliparous women. 1 in every third nulliparous woman gives birth by vacuum or forceps. There are some factors which can reduce the need for assisted vaginal delivery. First is continuous psychological or moral support by patient's family member during labor has been shown to increase the likelihood of spontaneous vaginal birth. Second factor, with epidural, lateral position 5.9 to 6% increases in chances of spontaneous vaginal birth. With epidural, delayed pushing for 1 to 2 hours recommended in nulliparous. With epidural, reduces rotational and mid-pelvic assisted vaginal birth. Third factor, without epidural, upright or lateral position also increases chances of spontaneous vaginal birth. There are some factors which can increase the need for assisted vaginal delivery. One is epidural analgesia. With epidural analgesia, mother did not have any urge to push, although it is less likely with newer techniques of epidural analgesia. Second factor is nulliparous. As I have already discussed that assisted vaginal birth is more common in nulliparous women. 1 in every third nulliparous woman gives birth by vacuum or forceps. There are some factors which have no effect on incidence of assisted vaginal birth. As epidural either is given in latent phase or inactive phase, it has no effect on incidence of assisted vaginal birth. Second is discontinuation of epidural analgesia during pushing also has no effect on incidence of assisted vaginal birth, but it increases women's pain 22%. There are some factors which have insufficient evidence for reducing incidence of assisted vaginal birth. First is regional analgesia technique. Second, oxytocin augmentation for women with epidural. Third is prophylactic manual rotation of fetal malposition in second stage of labor. Different studies shows different results. Like some studies shows that manual rotation success rate decreases in incidence of operative vaginal birth and also decreases second stage duration. Some studies shows corrected fetal malposition by manual rotation in early second stage has no difference in incidence of assisted vaginal birth. Larger randomized controlled trials are needed for this. Assisted vaginal birth GTT has been updated due to rising rate of cesarean section births in second stage of labor reflects that concerns about assisted vaginal birth, morbidity or loss of clinical skills. Second stage cesarean births have their own severe complications which we will discuss later on. Let's discuss preparation of patient. Regarding preparation of patient, clear explanation should be given to the patient and informed consent should be taken and documented in women's case notes. Regarding information of assisted vaginal birth, all these information should be given in antenatal period, especially if first pregnancy, because there are high chances of assisted vaginal birth in nulliparous women. And then take into account women's birth plan and rule out any specific restrictions and preferences and also explore these restrictions and preferences with experienced obstetrician in advanced labor. Information during labor should be given in between contractions and must be documented. Assessment findings reasons for proceeding to assisted vaginal birth, and verbal consent or written consent. All these information should be documented in patient's notes. Mid-pelvic rotational birth compared pros and cons of assisted vaginal birth with second stage cesarean section for given circumstances and operator skills. Trust should be established between patient and doctor, and full cooperation of both is necessary. Appropriate analgesia should be given. For mid-pelvic or rotational birth, epidural analgesia is better. Second option is pudendal block, which can be given in second stage of labor. Maternal bladder should be emptied to provide additional pelvic space and minimize a bladder trauma. Urinary retention and bladder dysfunctions are frequent short-term effects of assisted vaginal birth. Episiotomy and epidural analgesia both are commonly associated with assisted vaginal birth and also are risk for urinary retention and resolve after 24 to 48 hours of catheterization. Indwelling catheter has been removed or balloon should be deflated. Procedure should be attempted in aseptic techniques. Regarding preparation of staff, assisted vaginal birth should be attempted by experienced obstetrician or in the presence of experienced obstetrician. Operator should have knowledge of maternal pelvis, fetal skull, anatomy, and skill and experience necessary to assess the woman to complete the procedure and manage any arising complications, because inadequate training is key contributor to adverse outcome. Operator should have adequate facilities like equipments, bed, lighting, and access to operation theatre. Backup plan should be available for mid-pelvic births. Theatre facilities should be available to allow a second stage emergency cesarean birth to be performed without delay. Senior obstetrician should be present if an inexperienced obstetrician is conducting the birth. All complications like shoulder dystocia, perineal trauma, postpartum hemorrhage should be managed. Trained neonatologist should be available for neonatal resuscitation.